Okay, we're going to get started with chapter 27, anxiety disorders. We're going to talk about anxiety as well as obsessive compulsive and related disorders. So let's take a look at anxiety disorders. First of all, we need to have a working understanding of what anxiety is. So, in terms of anxiety, we need to know that anxiety can be defined as a feeling of discomfort, apprehension, or a dread related to anticipation of danger, the source of which is often nonspecific or unknown. Anxiety is considered a disorder when fears and anxieties are excessive, and they are associated with behavioral disturbances such as interference with social and occupational functioning. So, anxiety disorders are the most common of all psychiatric illnesses, and it can result in considerable functional impairments as well as distress. Who can tell me how much anxiety is too much anxiety? When anxiety is out of proportion to a situation that is creating excessive fear, or if it's interfering with the individual's social, occupational, and other important areas of functioning, that is too much anxiety, all right? Very important. So now we're going to take a brief look at panic. And panic is a sudden, overwhelming feeling of terror or impending doom. This is the most severe form of emotional anxiety and is usually accompanied by behavioral, cognitive, and psychological signs and symptoms considered extremely intense and frightening. So, here this slide just shows some symptoms of a panic attack. And remember that these symptoms or this information can be found in the DSM 5TR, and it states that an individual has to have at least four of the following symptoms. Those symptoms must be present in order to identify the presence of a panic attack. The attacks usually can last for minutes, rarely do they last hours. Some individuals often experience varying degrees of nervousness and apprehension between those attacks. And in addition, symptoms of depression are common. So the symptoms are listed here: sweating, trembling, shaking, shortness of breath, chest pain, discomfort, nausea or abdominal distress, dizziness, chills, hot flashes, numbness or tingling sensation, derealization or depersonalization, fear of losing control. The individual may say, it feels like I'm going crazy, or they may fear dying. So, predisposing factors include generalized anxiety disorder, and we're going to mention that as well as panic and generalized anxiety disorder. So, generalized anxiety disorder is characterized by persistent, unrealistic, and excessive anxiety or worry. This usually occurs for days, no more than about 6 months, and it cannot be attributed to organic factors like caffeine or hyperthyroidism. The anxiety and worry are also associated with muscle tension, restlessness, or feeling keyed up or on edge. Oftentimes, that's what the individual complains of. Panic and generalized anxiety disorder um, are seen together, and there are psychodynamic theories and cognitive theories that go along with it. So, I also want to mention with symptoms of generalized anxiety disorder, those symptoms are intense for the individual. They often avoid activities or events that could result in negative outcomes. Or you may find this individual spending considerable time in an effort to prepare for such activities. Anxiety and worry often results in the individual procrastinating in their behavior or their decision making, and the individual repeatedly seeks reassurance from others. Can you all think of anyone that might fit this diagnostic criteria? So we're going to mention the predisposing factors. And one thing I want to say about predisposing factors, this is going to be across the board with all of the disorders that we cover. So as you look at your exemplars, we have anxiety disorder, including PTSD. We have maladaptive disorders, eating, which includes eating disorders, personality disorders, addiction, somatic disorders, and then we have the subcontent interpersonal violence, abuse, neglect, bullying, and sexual assault. So, what I want to emphasize here, oftentimes there are biological aspects that go along with each one of these disorders. So, I'm going to mention an example, but keep in mind with each disorder, you're going to see genetic, neuroanatomical, biochemical, neurochemical processes that go along with the disorder. So, genetic vulnerability to panic disorder has been supported by family and twin studies. The twin study showed that at least 30 to 40% risk of heritability. It could be hereditary, in other words. There are some genetic findings that are indicative of the risk rather than the determinants of the illness. So, genetic factors can link some of these disorders. Current genetic studies are yielding more insight about the impacts of those environmental factors rather than the gene information, okay? So it's also research has also shown that structural brain imaging studies in patients with panic disorders have implicated pathological involvement. So when they looked at the temporal lobes, in particularly the hippocampus and the amygdala, I can't talk today, and the frontal cerebral cortex, they noted that patients with anxiety disorders had some pathological involvement. When they looked at the blood lactate levels, it was noticed that individuals with these panic and generalized anxiety disorder, their lactic levels were elevated. There's also been strong evidence that supports neurotransmitter norepinephrine in panic disorders. So, again, I just want to mention that you may see some of these biological aspects as we cover all of these disorders. The neurotransmitter serotonin and GABA are thought to be decreased in anxiety disorders. So I'm just mentioning these to you. It's just important to know that as we're covering all of the concepts, you may see some biological aspects that correspond with the actual disorder. Okay? So let's look at phobia. Some common phobias can be found in your book on page 544, 554, table 27-1. So as I'm calling out these page numbers, this is for your benefit. You need to dig into your book. Again, that's page 554, table 27-1, and look at some of those phobias. So let's discuss. A phobia is an irrational fear of a specific object or a situation resulting in intense aversion toward the feared stimulus. Exposure to that feared object or situation is typically accompanied by intense anxiety and panic attack. Can y'all think of anyone with a phobia? What about agoraphobia? Fear of being in places or situations which escape might be difficult or which escape might not be available. And this individual will develop panic-like symptoms or other incapacitating symptoms. Some examples of agoraphobia include traveling in public transportation. Do y'all know anyone that has a great fear of traveling in public transportation, or being in open spaces, being in shops, theaters, or cinemas. What about standing in line or being in a crowd? Being outside of the home or alone in other situations would be a good example. There are some social phobias, and there are also some specific phobias. Social phobias will include symptoms of excessive fear of the situation in which the affected person might do something embarrassing or be evaluated negatively by others. Do you know anyone that fears, I'm going to embarrass myself? I'm going to do something silly. I'm going to do something and I'm afraid everybody will laugh at me. That would be an example of social anxiety disorder. There are specific phobias as well, and this individual will fear a specific object or a situation that could cause them harm, but the person's reaction to them is excessive, unreasonable, and inappropriate. So, exposure to the phobic object produces overwhelming symptoms of panic. You may see them palpate, having palpitations, sweating, dizziness, and difficult breathing when we think about those specific phobias. Anxiety disorders can be attributable to other medical conditions, and I have those listed here in the slide. I'm just going to try to line up the slide with the actual capture so it does not look so big here. Just bear with me. So, what are some of those medical conditions that can produce anxiety symptoms? We look at the heart, we think about the endocrine system, the respiratory system, as well as the neurological system. Several medical conditions are associated with the development of these anxiety symptoms. When we think about the heart, the individual could have might experience a myocardial infarction, congestive heart failure, mitral valve prolapse. When we think about endocrine conditions, we think about individuals experiencing hypoglycemia or hypo or hyperthyroidism. Respiratory conditions could include chronic obstructive pulmonary disease, hyperventilation, neurological conditions, as well as seizures and encephalitis, okay? There are some substance induced anxiety disorders, and those are only diagnosed if the anxiety symptoms are in excess of those usually associated with intoxication or withdrawal. Substance induced anxiety disorders may be associated with the following things like alcohol, amphetamine or cocaine use, hallucinogens, sedatives, hypnotics, anxiolytics, caffeine, cannabis, as well as other substances. We're going to briefly cover obsessive compulsive disorder. Obsessions are intrusive thoughts that are recurrent and stressful. Although they're recognized by the individual as irrational, they continue to be repetitive and they cannot be ignored. Now, who can tell me the difference between the compulsion and the obsession? Anybody? Obsession is the thought where they're having those reoccurring thoughts or the impulses, and the compulsion is actually the act. So, an example of a compulsion would be excessive hand washing, ordering things, putting things in order, checking. I think about door checking or checking the stove or checking the iron or checking the flat iron. Praying or counting. An individual can't pass by anything that has layers or steps without counting. Or repeating words silently. Do you all know anybody that has exhibited any of these symptoms? Some other anxiety disorders include body dysmorphic disorder, hair pulling disorder, which is known as trichotillomania, and hoarding disorders. Let's talk about those briefly. Body dysmorphic disorder is characterized by the belief that the body is deformed or defective in some specific ways. The most common complaints involve perceived deficits in the skin, such as wrinkles or scars, the shape or the size of the nose, or the individual's hair. Other body parts can be focused on as distorted beliefs, including something is wrong with my eyes, my lips don't look right, look at my teeth, my stomach, genitals, as well as body weight. In some instances, a true defect may be present, but oftentimes, some cases, these people with body dysmorphic disorder also develop psychotic disorders. Do y'all know anybody who's had 10 nose jobs, for example? Or they've had several lip surgeries, for example. That would be an example of body dysmorphic disorder. It's just the belief that something is deformed or defected on their body in some specific way. Hair pulling disorder or trichotillomania. It's defined as the recurrent pulling out of one's hair that can result in hair loss. You've probably seen this individual. They're sitting at the desk or the table and they're looking at all the ends of their hair. And what are they doing? They're just pulling out hair, okay? The impulse is preceded by an increased sense of tension, and it results in a sense of relief and or gratification from pulling out their hair. So they feel a sense of relief. The most common site for pulling hair is the scalp. You may see them pulling hair from their hair follicles that's located on the head, their eyebrows, their eyelashes may also be an area in which the hair on the body grows. Let's talk about hoarding disorders. I know you all can identify or define what that is, and that's persistent difficulties discarding or parting with possessions, regardless of the actual value. I'm sure at some point all of you have seen an example of hoarding disorder on television. The individual with this disorder, what do? Collect items until virtually all surfaces within their home is covered. You may see them going down a narrow pathway, winding through stacks of clutter in which they're trying to walk. Some of these individuals also hoard food, animals, or they may keep dozens or hundreds of pets, often in an unsanitary condition. What do y'all think about hoarding disorder? That's not you, is it? All right, let's talk about some outcome criteria for the individual with anxiety disorder. We want the individual to recognize signs of escalating anxiety and intervene. We want to try to intervene, or they need to intervene before they reach the panic level. We want to maintain anxiety at a manageable level and make sure that independent decisions about life situations can be made. So, what do we want them to do? We want them to recognize symptoms before reaching panic. We want them to maintain their anxiety at a manageable level. We want them to verbalize a plan of action, without going into panic. We want to know if they're able to maintain their anxiety without resorting to the use of a realistic ritual like OCD. For the OCD person, we want them to demonstrate more adaptive coping strategies for dealing with the anxiety instead of that behavior itself. Going back, checking the door, going back, counting, turning the stove off several times, or making sure it's off. We also, for body dysmorphic disorder, we want them to verbalize a realistic perception of their appearance and express their feelings that reflect a positive body image. For the individual with trichotillomania, we want them to develop more adaptive strategies for coping with stressful situations. Again, all of this can be found in your book, and they're all listed after each topic. So what am I saying? I want you to be familiar with the outcomes and goals for everything we've discussed so far. Let's talk about the planning phase. Anxiety is defined as a vague, uneasy feeling of discomfort or dread, accompanied by an autonomic response. The individual may experience apprehension caused by the anticipation of danger. So, we want to set some goals as well as some interventions. The goal would be a short term goal as well as a long term goal. Timelines are individually determined. So, an example of a short term goal would be the patient will verbalize ways to intervene in their anxiety within the first week. How can I stop my anxiety from going to panic? That would be a short term goal. A long term goal would be maybe by the time of discharge, the patient will be able to recognize symptoms, including the onset of anxiety and interventions before they get into the panic mode. So, what would be some nursing interventions? Things that we're going to do. How are we going to respond? We don't want to leave this individual who is experiencing panic attacks alone. We want to stay with him or her and offer reassurance as well as safety and security. At this level of anxiety, patients often express fear of dying or going crazy. So, we need to stay with them, okay? Again, we want to be calm and non-threatening. We want to approach them in a matter-of-fact approach, okay? Use simple words and brief messages. When you're speaking to them, speak calmly and clearly. Explain to them what's going on. They may have some hyperventilation, and hyperventilation causes the amount of CO2 in the blood to decrease, resulting in lightheadedness or a rapid heart rate or shortness of breath. So if they're hyperventilating, you want to help them breathe into what? A small paper bag. So you're going to cover their mouth and nose. 6 to 12 natural breaths should be taken while you alternate with diaphragmatic breathing, all right? Keep the immediate surroundings to a low stimuli. Dim the lights. Make sure they're not in a large crowd. Simple decor. Administer any anti-anxiety medications if needed. You want to assess the medication as well as the side effects, effectiveness, and for adverse side effects. When the level of anxiety is reduced, you want to explore with the patient possible reasons for the occurrence. Let's think about it. How often or how well would the individual be able to understand any information we're trying to teach them at the peak of their anxiety? They probably wouldn't, right? So when would be the best time to teach them or the best time to give them information? Once their anxiety level has been reduced. So you want to teach them about symptoms of escalating anxiety. Discuss ways on how to relax, such as deep breathing, physical exercise. Go take a brief walk or jog or meditation. The patient will need to determine methods in which are most appropriate for him or her. And that's going to always be key. They need to be involved in the care and determine what method will work best for them. So, ineffective coping skills, there's goals and interventions for these as well. And these can be found in your book also. So, I'm coming straight out of your book, and the care plans are listed in your book for patients with anxiety, obsessive compulsive, and related disorders. So rather me read all of this information off to you, I'm going to redirect you to your book. There is a care plan in your book. Right now I'm looking at page 562 that will go along with all of the anxiety disorders, and it breaks it down into several different categories, okay? So ineffective coping is actually in your book on page 562. All right. So let's talk about the concept care mapping. And who can tell me what exactly that is? We want to get in everybody on the team, and we want to get the patient involved, their family involved, because that's going to be important to the patient as well as their relationship with family members when they're discharged, okay? So we want to use a diagrammatic teaching and learning strategies that allows visualization of those other relationships. We want them to understand if they have any medical diagnosis, as well as nursing diagnosis, and assess their data as well as the treatments. So we're going to take a look back at the individual's care plan and make sure we're meeting all of those goals. We also want the role of the client teacher to be thought about as well, because it's very important for these patients in the psychiatric area, okay? So once we've done all of this, we want to evaluate what we've done and determine whether or not it's been effective. The final step in the nursing process, and we all know it, is a reassessment. We're doing that to determine if the nursing actions that we've implemented have been successful, okay? So think about that as you're using the clinical judgment model. That's that new terminology we've mentioned. We're going to go back at the end every time we've implemented our interventions, and we're going to reassess or take a look at and see if what we've done have been effective for the patient. And guess what we're going to do it if it has not been successful? We're going to come up with something new, right? We're going to implement some new strategies or some new interventions so we can help this client meet their needs. Will we all agree? Yes. So again, evaluation of the nursing actions, and you're just going to look at anxiety, OCD. Number one, can they recognize what symptoms they have before they get to anxiety? Did they learn any skills to help them prevent from going to anxiety to panic? Can they demonstrate activities most appropriate to help them manage their anxiety? Can they manage their anxiety without medication? So let's mention some treatment modalities. Treatment modalities are going to be covered in all of these topics that we're going to cover. So number one is going to be individual psychotherapy. Who can tell me what that is? Supportive psychotherapy is designed to help the patient identify his or her personal strengths. What am I good at? Also to explore adaptive coping mechanisms. We're going to look at the individual's insight, how well they're oriented, and it's designed to help the patient identify, explore, and resolve those psychological conflicts that contribute to their anxiety. So what the individual is going to do is just take a good look at themselves and try to figure out what's happening when I have a panic attack. What's going on with me? Is it a certain area? Is it more job related? Does it happen every time I'm at home? So cognitive therapy strives to assist the individual in how to reduce those anxiety responses. And that's going to be key. So we have behavioral therapy as well. And I just want you to review over that. And we have other non-pharmacological treatments. And we all know some of those. And those include deep breathing, progressive muscle relaxation, using imagery, mindfulness, meditation, and other exercises. So I'm going to briefly mention behavior therapy can include desensitization and implosion therapy or flooding. And what that is that's where they gradually expose the individual to a phobic stimuli. It can either be real or imagined. And what it's going to do with implosion therapy is it's going to flood. The patient will have the information concerning the triggers or the stressors to the situation, and we want to see how they react or what is their anxiety level like when they're reliving or thinking about the situation. So in all actuality, the therapist is going to describe anxiety-provoking situations with vivid details to the patient. And the therapist is going to observe the patient's response. How do they respond to the situation? Is it more anxiety-provoking or is it more in a therapeutic endeavor. So it's just looking at how they respond, okay? We have a lot of treatment modalities that can be used. Of course, we're going to do what before we get to medication? I'm going to roll the slide back up. We're going to use all of these others before we get into medication, okay? So you notice you have several listed here. These anti-anxiety drugs can be called, or is also called, anxiolytics. And they've been referred to back in the old days as minor tranquilizers. These anti-anxiety agents are used in treatment of anxiety disorder and anxiety symptoms. They can also be used with alcohol withdrawal, skeletal muscle spasms, seizure disorders, and for preoperative sedation. A list of these anxiety disorders medications can be found in your book on table 27-4. So 27-4 is where you can find these medications. So be sure to refer to the table. Again, that's table 27-4. And take a look at these anxiety meds, which is on page 571 in your book. I do want to mention, oftentimes with anxiety, and I'm specifically speaking to anxiety, panic, OCD, all of those things I just covered in these slides. Oftentimes, it's not uncommon that the individual will be started on an antidepressive initially. So you may see some antidepressants used before going straight to the anxiolytics. So examples of these, where it talks about management of the illness, turn back to page 568 in your book. Put a star by these because it goes over medications used for generalized anxiety disorders, phobia disorders, OCD, body dysmorphic, and stress management. So review box 27-6, and it's found on page 568 in your book, okay? Treatment modalities. So here it mentions everything I kind of just mentioned. Medication for specific disorders. So for panic disorder and generalized anxiety disorders, you see anxiolytics, antidepressants, as well as hypertensive agents can be used. Oftentimes in practice, we'll see antidepressants used first before going straight to an anxiolytic, right? So phobia disorders, you're going to see the same. So here are some sample test questions. I'm going to give you time to read over this and let me know what you come up with. You got a newly admitted diagnosed client with OCD. They're spending an hour packing and unpacking, folding and refolding their belongings. What is the most likely reason for this behavior? And you all know the answer. We said it's A. Oftentimes the act is a way of what? Relieving that anxiety. And we see this individual has the most likely disorder of what? OCD. Very good. Anxiety disorder. For the last year, a college student continually and unrealistically worried about their academic performance and love life performance. The student is irritable and suffers from severe insomnia. This behavior is associated with which diagnosis? What do y'all think? If you've guessed generalized anxiety disorder, that is correct. So when caring for a patient who's experiencing a panic attack, which of the following actions should be implemented? A panic attack. Remember, we just talked about these. If you've guessed D, D is correct. What did we say? Are they going to learn anything or receive any teaching or understand any teaching when they're having an actual panic attack? No, they are not. We want to wait till they calm down And we want to use simple words, brief messages, speak calmly and clearly, okay? Very good. What should the nurse plan to teach a patient who's taking Xanax 3 times a day? Do we want a patient on Xanax for the rest of their life? What is one of the problems we see right now in Mississippi? Opioids mixed with what? Anxiolytics, and what are they causing? Respiratory depression. So the individual, the correct answer is if they stay on this medicine for extended periods of time, there is a potential for dependence and tolerance, and there's also a potential for what? Abuse. So if you're starting an individual on an anxiolytic or patient teaching that goes along with it, this is for extreme circumstances. You're not, we don't prescribe it. It's not designed for you to stay on it forever. We're just going to kind of get you over the hump, and then we're going to have to eventually taper you off. This is the end of this lecture. Thank you for attending. Be sure to use this lecture to help you fill out your ticket to class.